Dun,
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 dun.
dun.
So we're doing a case study on a SAM patient tonight. Our goal is to be able to meet once a month and talk about various heart cases and get a chance to meet these delightful gentlemen.
Oh.
I know, and talk to them face to face, one on one, and ask questions. I know. Is the pressure on? Okay, so about 15 years ago, we treated our very first patient that I can recall anyway in the ICU that was diagnosed with SAM. And the patient presented with the usual post-op orders and care. He was a cabbage on a low-dose nitro drip that I can recall. He was hypotensive. The nurse initiated minimal dopamine drip, just at 2 mics. However, instead of getting any better, the patient continued to get worse. And so she called asking for more, and indeed they upped the dopamine up to 4 mics, and then they added epi, and then they added neosynephrine, and they gave fluid boluses, and yet in spite of all of these measures, the cardiac output still wasn't any better. It just kept getting worse. Acidosis required a bicarb bolus, and then Dr. Gadiani, who was the surgeon at the time, ordered a stat echo. At the time, we were all thinking it was going to be a tamponade. So there was a brisk conversation
Ventricular tamponade.
Mechanical.
Ventricular tamponade.
among the attending doctors, and they called it SAM. And they said, turn off all the inotrope agents, dopamine, epi, now, and because we were seriously compromising the patient's survival. And the new regimen was to treat with a vasopressor only, neo, and a vasopressin drip, fluid bolus, and keep and paste. We had a hard time turning the dopamine and the epi off, even though the blood pressure was 60 systolic, but we did, and the patient recovered and made it out of the ICU. So that was my first SAM
Wow.
acronym, new acronym to learn. And we managed several more SAM patients after that had emphatic orders, no inotropes. And then later there were surgically corrected SAM patients that could have a low dose inotrope. And then there was patients that were mild SAM that could have a low dose inotrope. So each case is unique, and I don't
Yes.
think there's a way that you can say every SAM patient has only one method of management. So we do know that they require vigilant observation by the bedside nurse and effective communication with the surgeon. So they can be some of our most challenging patients. So this patient we're going to talk about today is Mrs. G. She was a 75-year-old lady who was
Is a 75-year-old.
Sorry, she's not gone. A post-op AVR, LVOT, and a cabbage, and a left ventricular septal resection and myectomy.
Yep.
She had history of progressive symptoms of aortic stenosis, CAD of her RCA, but a relatively well-preserved ventricular function. And your comment at the end of the op note was, you noted some residual systolic anterior motion that improved with low-dose neo.
Yes.
So our questions to start with is, what is SAM, and can you illustrate it on the board for us?
Great. Those are fantastic cases, actually. And these are tough. I'm going to pick on the youngest, Megan. What is SAM?
Come on.
It's your charge. What is SAM? What does SAM stand for? And you can ask a friend, 50-50, or call somebody here too. You can pass it on to Tony if you want to.
Okay.
Tony, what is SAM?
Systolic anterior motion
Of what?
of wall abnormality. So like, you know, with the, it's almost like LVOT. You're
Is it like?
It's not because the LVOTE is the response in the myectomy to the SAM.
SAM. It is systolic anterior motion, but it's of the mitral valve. Oh, I always meant of the mitral valve. So I drew out an illustration here of what the ventricle, this is not great, and Adam would draw it a little bit differently. This is the way I draw it. Imagine this is the ventricle here. Here's the left atrium, right? Here's the aorta. Can you see that? I'll stand here like this so I don't block the images. Blood drains from the lungs to the left atrium, right? Gets oxygenated, drops here diastole, and what happens? Heart squeezes, and guess what? All this blood that pools here goes, boom, and then it careens out that way. It's simple. It's just fluid physiology. And if you're the mitral valve, when this flies forward, the mitral valve actually moves this way, posteriorly, and it closes over here. And if you were to look at this in cross section, here's the mitral valve. It's really big. Here's the aortic valve, and it's open. There's a little smiley face that's in the back of the heart, the posterior section. That's the meeting of the mitral and the anterior and posterior leaflet. This is the anterior leaflet. And the posterior leaflet of the mitral valve is essentially two lips that open and close. Okay? But again, in systole, all this fluid, all this wave of fluid pushes this valve that way. Okay, that's normal. So what's SAM, or who's at risk for SAM? Well, there are ventricles that are thick. Here's this ventricle here that's thick and has this very thick septum. Here's this hypertrophic, this septal hypertrophy, if you will, asymmetric. Now blood is in here in the left atrium, drops here, and as the heart squeezes, what happens when the heart squeezes? All this moves forward. These leaflets close, but guess what? Blood is going here and bouncing right back here. It's not really going that way because it's blocked here. So what does that do to this leaflet? It pushes it over this way and obstructs the heart. I kind of tried to depict it here. Here's the aortic valve here that's open. There's muscle here. And instead of coapting back here, you've got this coaptation that occurs here, and the leaflet drapes over here and blocks outflow. It's like a rag sitting in the wrong part of the heart. So what are conditions that make this worse? We were just talking about that with Colleen. Oh yeah, those are the Adam.
Well, I didn't learn it as Sam. I learned it as Sam Ash when I was in medical school. And that's what Luis was just saying. The SAM is the systolic anti-motion of the mitral valve is one side of it, but what if you add to it asymmetric septal hypertrophy? Then you've exacerbated it. And then in my brief career, because I'm only now 29 years old, it's had different names, all of these things. It went from SAM Ash, then it was idiopathic hypertrophic subaortic stenosis. So IHSS that term was bantered around.
That's synonymous with SAM?
Well, it's an idiopathic, meaning we don't know what caused it. Hypertrophic, meaning
Yeah.
subaortic, because what
Under
Luis is
the
depicted
aortic
here
valve
is it's
is-
right under
is
the
the
aortic
stenosis.
valve.
Right.
And one of the things that is hard, and many heart surgeons don't even know it, because we look at the aortic and the mitral valve mostly individually. When we're doing an aortic valve operation, we look at the aortic valve. When we're doing a mitral valve operation, most surgeons look at it from underneath and they don't see them together. These guys that's it. They're right next to each other. And when we do our double patch, double valves that you all hear, it becomes blatantly obvious because we remove that aortomitral connection or the aortomitral continuity. These valves are juxtaposed. And so the hypertrophic subaortic stenosis is similar to the asymmetric septal hypertrophy. And also the later term also that people will say sometimes, although this is more of a congenital problem, is HOCM, or hypertrophic obstructive cardiomyopathy. And these all kind of lead to the same physiology that Luis is talking about. It's a set of circumstances that bring that forth.
And then there's, these are diagnoses where the ventricles now this is a different scenario that we now see where patients are older, they're hypertensive, and the aorta elongates with hypertension as we get older and actually gets stiffer too in systole. The heart, for many years, the heart is pumping through the aorta, and slowly it's like your nose gets longer, your ears get longer, and guess what? Your aorta can get longer too. And when that happens, the angle between the aorta and the mitral valve changes. So instead of being,
Gets fat.
here's this sort of flat angle, here's the aortic, and here's the mitral. Do you see that? Almost like a flat line or a little obtuse. Look at this line here, it's almost right angles. So what happens then? We look at that, we say, oh, because what happens is that even though this isn't that thick in these patients, and let's say they have aortic stenosis on top of that, or coronary disease. Let's just say they have coronary disease, just like that patient that you had. Comes off, they've been doing fine, right? But blood goes in here like this, drops, and when the heart squeezes here, it's bouncing right back up. It's not going over here, it's bouncing up and potentially getting this leaflet trapped this way. It's like a surfer getting caught on the wave instead of being outside. So, anyways, what makes this condition worse? We were talking about inotropes. Why do inotropes make this worse? Because the heart is now squeezing even more, and it's creating even a smaller cavity. Now the leaflets get trapped in there, and it's completely obstructed. What else did we say makes it worse?
Inotrope's meaning chronotropy.
Chronotropy.
The faster that the heart beats, the less time
Less
it
filling.
has to fill.
Right, so
it's
what makes it
easier.
better? Better yet, what makes this better?
5617,
Volume.
Dr. Engel.
Volume.
Filling time, so, yeah.
Beta blockers keep the heart slow.
Beta blockers can, instead of making the heart, be hypercontractile, it keeps it from actually obliterating itself. Volume, right, keeps these walls now back. Now the heart's maybe full, but at least there's a channel for blood to flow through, because the anterior leaflet is now having time to swing back posteriorly. It's when this leaflet comes in this way, instead of these two leaflets coming in this way, they're moving into the direction of the outflow. It's like kelp being caught on the wrong side. Vince used to have a good analogy. Imagine your lips are the mitral valve on your face, and I take a high-powered jet like the water hoses, and I aim it right to your chin, called the aortic outflow tract. Well, nothing's going to happen to the lips, right? That's normal physiology going that way. The lips are stay closed. The minute I move the jet towards your lips, you just go like that. Lips move over here, cause MR2, and make this condition worse. So we have to, in this case with Mrs. Giovanelli, I tried to cut out a little piece of muscle. And you're supposed to go all the way down. Let's look at her echo now. Actually, let's look at echo number 49.
So this is
Oh,
how you
no.
managed it medically, surgically.
Surgically, that's okay.
You still remember your login?
Well, I just want to bring up one other thing, because you mentioned
Yeah.
what was it to treat it. There was another thing that was mentioned to treat it, and that was neosynephrine or vasopressin. So why do you expect that would help? As opposed to
Inotropes.
inotropes?
Why does,
Because
Because you're
it's
not
just-
beating the heart, you're you're constricting just by upping up our SVR. Yeah. Upping up our pressure.
no, because now the pressure's here. This is where the pressure is transmitted with SVR. Now the heart actually has to work a little harder to get blood out.
Yeah.
And in doing so, it isn't as vigorous. It's actually it allows it to fill. So some of the way these patients protect themselves by chance is to somehow develop aortic stenosis.
Which is the ultimate pressure, as far as the
here's-
ventricle is
So
concerned,
here's a
right?
Really?
patient.
That's
Here's a
interesting.
patient that develops aortic stenosis here. So now this heart is having a hard time pushing blood out here, so it has to fill more, and it's less likely to
A glove
create
would be
SAM.
helpful.
Well, how do you kill that patient? You replace the aortic valve.
Huh.
Put an aortic valve or a TAVR, and suddenly you've got a patient that you don't know why. They're in a low
SAM.
cardiac output state, because now they're hypercontractile. Now all the outflow's open, and this valve here is being trapped down below. This is this lady. I don't know if you guys can see it. You can see it clearly, a little bit.
Say it again.
Here's the left atrium. The aortic
it's
valve,
coming up.
you can't see very well, but it's calcified. She has aortic stenosis. But immediately I can see that the angle here is, here's the aortic angle, here's the mitral valve. It's a little more acute. And it looks to me, if I were to draw, if I was a, just basic fluid physiology, how's blood gonna come out to the aorta? Well, there's this big septum here. So blood is bouncing back and forth. She doesn't really have SAM now, but I had a feeling that if we replaced this aortic valve, we were gonna end up in what we call sort of a suicide condition.
Okay. So if you have so say the blood wants to shoot out the end of the glove, and you have aortic stenosis, you're obstructing it, so the heart gets bigger and then goes out. But if there's no aortic stenosis,
You relieve it, heart's all.
then the heart never fills up completely because there's no afterload
Oh,
obstruction.
interesting.
So
So it keeps it up.
the afterload obstruction,
Aortic stenosis is actually helpful for those patients.
did that make sense to you?
Yes, yeah.
Yeah.
And so,
They
when I say
actually
that
develop-
neosynephrine and aortic stenosis are the same thing, as far as the ventricle is concerned, it's just thinking, what's the pressure that I'm working against? And it could either be a high blood pressure,
Uh-huh.
or it could be aortic
Stenosis.
stenosis. So people that have really high blood pressure without aortic stenosis still get ventricular hypertrophy. That's one of the signs of hypertension. And people that have aortic stenosis without high blood pressure get ventricular hypertrophy because as far as the left ventricle is concerned, it's the same thing.
Oh, interesting.
So by relieving the aortic stenosis, you're essentially giving a hypertensive patient a bunch of nitrite.
Which is not
it's
good.
Not good.
well, it's
Well, not good
it's
for Sam.
normally good, but it's not good for these guys.
It makes it worse. It makes it worse. And this patient also, the little surgical tidbits, but there was calcium on the mitral valves, which meant that this posterior leaflet, instead of being flexible and allowing it to come in, this was already stuck up here anteriorly, so it was almost facilitating potential SAM. This leaflet had a lot of calcium to it. So that was before, and then we went in, replaced the aortic valve, cut out a piece of muscle. Number 79, is that what number it is there? Any questions about the physiology? Pretty
How come
clear?
nobody's ever explained it this way before?
Because he never asked.
You never asked.
And that's why we're here. So it's just,
If a patient came in without heart surgery,
Yeah.
you put them on inotropes, what would happen?
Die.
Would they still?
If the patient came in with, usually these patients who have ASH, SAM, can't walk very far. They faint, believe it or not. They sit there and hyperventilate. They drink a lot of water. I have a 49-year-old guy from Fresno, Carpenter. Says he drinks about 50 bottles of water a day. And he's doing it to keep his volumes high. He knows that when he's not drinking water, he's lightheaded and almost falls. And he's got HOCM. He's got hypertrophic obstructive cardiac. He needs a myotomy myomectomy. And he's trying to get by for a couple of months as his insurance changes and such. But that's what happens to those people. But now, if he ended up in trauma, for example, with a broken, you start doing the wrong things to him, you can end up with a serious situation where he is now obstructed and tamponade. It's cardiac. The heart is obstructed, so volume can't go through. The right heart's like this. The lungs, you go into pulmonary edema.
it is a tamponade. How
It's a
interesting.
tamponade. Yeah, it's
Yeah.
pretty much, it's the same tamponade numbers that you get. Yeah.
Right.
Yeah.
That's number 7.
That's number 7.
Denied.
We're off bypass. Just a little suggestion here that I did this little, I call it an insufficient amount of muscle that I resected.
Well, it could just be the cross-section that we're taking.
Yeah.
There could be a channel in
I
between.
cut out like a big sashimi piece of meat, but you really have to get down there. And the volume now is less. You can see that this heart is not filled very well. These are stiff little hearts, right? So we want a volume expanded. We want to slow it down. We want to increase afterload and not create this hypercontractile situation where the heart is squeezing and then obstructing itself with this leaflet ending up here. You can imagine a trap that's in the wrong direction. Does that make sense? Can you guys see that on the echo?
So post-operatively, you still go with the same concept of no inotropes.
Yeah, no inotropes. You know, we had a SAM patient recently, about a couple of months ago, where we were actually dying. Cardiac output was 2 for a couple of days, for about 24 hours, acidotic. We got Nellis involved, and Nellis said, let's try dobutamine.
That's
You know,
our question. That's
Well,
what,
you know, these are concepts and these work, but sometimes, you know, we gotta use sometimes we gotta think outside the box. And somehow dobutamine works.
She came back on WB and.
No, this lady.
No.
This one?
Dopamine and epinephrine.
It was the one
No.
before that.
Dopey and Neo.
But
She was
I just
on
want
here.
to illustrate what Luis was saying before, because it's very well seen on this echo. You see this knob here? And look at the angle between the aorta and the ventricle.
Here's the
Let's now
aorta.
let's make the aorta longer because she's older and she has hypertension. So the aorta is longer and it pushes the heart in a more, because the heart has nowhere else to go, so this U is now like this.
Transverse.
It's becoming more transverse. Instead of it being up and down, it's more transverse, and you have this knob here. And that angle makes it more difficult for blood. It actually leads to obstruction. So imagine if the heart was more this way and the aorta is pushing that way, which is what happens with advanced age. So the aorta gets longer and the heart gets more transverse. And that's something that we frequently see, that the aorta has pushed it down. And you can't just pull it up because it happens over the course of many years. You can't just yank it up and expect it.
You're a little old man whose aorta, or a little old lady whose aorta gets longer and the heart gets transverse, and you add that to a little mitral valve problem where it's floppy and excessive, and you end up with a leaflet that's obstructing. And then you echo him, he's got aortic stenosis, that's his problem. Go in there, do a TAVR, and people have died actually post-TAVR. All of a sudden they're crashing, and guess what? It's a
That's it.
learning lesson in there because they don't know about this concept. They're just starting to learn. They give boluses of epi, and guess what?
Right.
They crash and die and burn. And someone says, oh my God, stop the epi.
Right.
Use Neo, volume resuscitate. Adam did a fantastic, he decided to pace this lady because she was not filling correctly. She was irregular. She was in heart block, I think. Is that right, Adam?
Right,
So here's this
that's
ventricle that isn't getting extra filling from the atrium. As soon as Adam paced her, now she had a ventricle that was full.
well, synchronously paced.
Yeah, synchronously pacing her. He
Yeah,
expanded the
she
ventricular filling time, ventricular volumes, and therefore the heart wasn't collapsing on itself. The ventricle wasn't collapsing on itself.
so I think one of the, we were asking as far as post-operatively, is the goal to kind of keep the CVPs a little higher on these post-operative
Probably.
patients?
Yeah. Yes. I mean,
Okay.
not always, but yeah.
Just an idea.
Volume, better a little volume overload than dry.
And then when you use the dobutamine on this patient, which kind of surprised, I remember you were asking about that.
We were
'cause
all
it's some-
surprised that it worked.
So
But-
it's not your first, it's what she's trying to say, it's not your first line agent.
I don't remember that patient being a pure SAM patient. There might have been, I mean, don't forget that some of these people can also have shitty ventricles.
Right.
This lady doesn't have a shitty ventricle, but if you have SAM evidenced on your echo, but
Uh-huh.
you also have a shitty ventricle, I think that patient
I
had.
don't think it. I don't
No,
think
she had a
it-
good ventricle.
She had a good ventricle,
According to him.
but a
But
lot of
just
these-
had some
Not
patients
this
in-
lady, I'm
Oh.
talking about the
Yeah,
lady that
another lady.
dobutamine was started on.
Yeah.
Oh, that's another
This lady's
one.
ventricle was fine. The lady
Right.
because if it's purely SAM, then dobutamine should kill the patient pretty well.
But it was a low dose. He started at a low dose, and who knows? And sometimes all it takes is, here's a stiff ventricle that can't fill and relax, and as much volume as you give, the right heart's filling, the left heart is still empty because it's thick. And now, this physiology begets acidosis and local, the heart isn't being well perfused by its coronaries, and it's getting thick and metabolically perturbed. I'm just throwing it out there. Maybe dobutamine somehow relaxed the ventricle a little bit more, and now all of a sudden we're feeling, and the heart's, although it's a little more hypercontractile, it's expanding to accommodate more filling. I don't know.
It looks like you gave it a try, and it looks
Those are-
like it worked for a while, and then you guys changed
Oh,
your
no,
mind
that
and it
was this
stopped
lady.
with
This
her.
lady didn't work, yeah,
And it stopped.
yeah.
One other thing in terms of the treatment, so Louise talked about, what else can we do? We can get rid of the septum,
Uh-huh.
right? But what if we got rid of would that help?
Do you replace the mitral valve?
Or what if we did, would that help with this situation?
I would say yes.
You would be right.
Absolutely. There'd
So-
be no systolic anterior motion, so.
Because as I always say, you can't have SAM without
You just have sa.
And SA's fine.
Uh-huh.
So you can't leave somebody without a mitral valve, but
Okay.
Louise actually developed a procedure of a partial mitral valve repair where you restrict the posterior leaflet.
You force this leaflet to just stay here. And if it stays here, the anterior leaflet has to kind of reach over to
The
collapse.
anterior leaflet has to go over.
And this
Oh.
lady here, her posterior leaflet actually had some calcium here like this. And then it kind of dove over here. So it was almost a setup potentially for SAM, so. We thought we could get away with this. The guys that do the most operations doing this hokum is surgeon at the Cleveland Clinic. I've seen him do several of these. Does an amazing job cutting the muscle. But,
Did I do something wrong?
No, I need to ask permission to extubate because my gas is 7.28 and we're protocol.
Oh, yeah, that's fine.
Thank you.
But yes, in terms of replacing the mitral valve,
Uh-huh.
yeah.
you could, absolutely.
You can correct the
The problem
SAM
is
then.
that you can make certain mistakes when you replace the mitral valve, and that's where experience really comes in, and experienced valve surgeons. If you use a mechanical mitral valve, right, a mechanical mitral valve is a flat disc. It doesn't have a profile. And so under any circumstance, if you replace it with a mechanical valve, it's not going to get in the way. So
There's a mechanical valve just sitting here. Imagine, here's the disc. Now blood goes in this way, and as the blood pops back open this way, guess what? This closes, and it just goes that way.
But if you use a bioprosthesis, you've all seen what the bioprostheses look like? They have a profile.
Stents, they have stents. They have 3 prongs.
So they all look like this. Right, I mean, I can't draw it in 3 dimensions, but the leaflets all are draped from those, and so, yes, it's a disc at the bottom, but it also has a height to it. And very frequently, you'd be surprised to know that some surgeons implant their valves without paying any attention to how they orient that. And if this is oriented in such a way so that one of these stent posts is in the outflow tract, you'll wind up with an
So
octosimilar
imagine this valve
problem.
now it's not a flat disc, but it's a valve with a stent like this. Look at this. This is obstructing.
It's totally obstructing.
Yeah.
Now, you
I
can't
You
put it
have
in
to
such a way
rotate
where
the
you
valve.
rotate it.
Huh.
And furthermore, that this is one of the reasons that we moved away from the mosaic valve and move towards the epic valve because those stent posts are a little bit
smaller
lower.
in the mitral position, they don't stick out as much.
So why are they there at all?
That's how they
I'll bring
support
you a
the
valve and I'll show you.
That's how they support the valve is sutured up into them, it goes down, and it's like a pocket, 3 pockets, the valves, and at the joint here are these stents.
So does that mean someone's not sewing in that extra leaflet?
And many times you'll go in and see if
No,
you're
we're
doing
taking out the
aortic valve.
leaflet and replacing it with a tissue valve.
Right.
The tissue valves are on a stented platform.
If they're not-
And they're
they're not
obstructed
correct.
potentially if you put them in the wrong way.
And you'd be surprised because that relationship between the aortic valve and the mitral valve isn't always well understood by the people that put it in. And in fact, I've been here since 2006. Between Vince and Luis, and I can't remember whom, I've been involved in at least 2 or 3 cases where somebody else's valve had to be explanted because the stent was in the aortic outflow tract. That relationship is very juxtaposed to each other.
And the other problem is gonna be when people start doing transcatheter mitral valves. Because you don't take out the mitral valve, you end up putting a prosthesis here, then you put this, this spring in here called the mitral valve, and guess what happens to this leaflet?
Obstruction.
Potentially? It's going to obstruct,
Huh.
especially if you have someone like this who's a little susceptible. So it's gonna be a big problem, how to deal with the anterior leaflet, with patients who have these valves that close in these cylinders. It's nice, but that anterior leaflet, you're just pushed into the outflow.
Hey Luis, when you put that posterior leaflet to where it doesn't really move and the
Yeah.
anterior leaflet goes to it, it does that naturally, or do you have to do anything to that anterior leaflet?
No, this is fixed, and as blood swirls out that way, the anterior leaflet gets pushed by the wave over here.
And it goes more, it closes more
It's more
posterior.
likely to
Asking it
close
to
here.
close more posteriorly.
Because these are kind of tethered together, they're little cords that kind of keep them, they share cords together, so if one leaflet is over here, maybe we can drag its partner, when it comes out the ventricle.
And that's a valvuloplasty, a
Yeah,
repair?
mitral valve repair, yeah.
But it's a partial repair, you're only asking a part of the valve. First of all, the valve wasn't, in most cases, in this cases, there's a little bit of calcium in the annulus. In most cases, you're actually doing something to a normal valve, which is never a good idea. Because as you're looking at it and it's normal, you don't take a good situation and make it worse. But in this particular situation, you're essentially tethering up the posterior leaflet and asking the anterior leaflet to come more posteriorly. And in so doing, and this happens passively, this isn't active. I mean, yes, you aggressively tether the posterior leaflet, but then the normal physiology will make the anterior leaflet come further to the back.
So, yeah.
Now, why didn't Luis do a better job with this septotomy? I mean, why not just cut the whole damn, I mean, geez, what's on the other side of that, of that chunk of muscle? The right ventricle.
Yeah, so the right ventricle is here like this, here's the tricuspid valve here, the right ventricle sits here. So you could end up cutting into this and creating a VSD, which, yeah.
So you're like only like a couple of millimeters away from creating a disaster and a VSD.
But no hole.
I'm sorry?
But no hole.
Putting a hole, which is not an easy hole to fix, because if you get a VSD in the membranous septum, it's one thing, but if you get it down and deep in the muscular septum, it's difficult to find and difficult to fix. So you want to take as much as you possibly can without causing damage, which is a difficult thing to do because the relationships between the structures is different depending on the angulation, the thickness, and you're diving a knife deep down into the abyss, and there's other structures down there that are also potentially able to be damaged, like the papillary muscles or the cords of the mitral valve, so you can cause significant damage. And in this lady, we did cause some, Luis took a lot of muscle, so I disagree that we didn't do a good job in taking the muscle. We took out enough muscle such that we damaged her conduction system, right? So she was in complete heart block. And she was in complete heart block either from debriding the aortic valve, but more likely from the amount of muscle that was taken from the septum, or a little bit of both.
Did she get a permanent pacer then?
Well, that was the point. So the treatments for this, right, are increase the intraventricular volume or increase the afterload, right? So we talked about ways we can do that. You mentioned some volume, slow down the heart rate, give the heart more of a chance to fill. But in this case, she didn't have AV synchrony, so we thought maybe that the atrial kick would help to increase the interventricular volume.
Absolutely, but
Yeah.
postoperatively, I mean, permanently, will she get a permanent
She
pacer?
did, so.
She- a
because
per- oh, she got a
came out of the
permanent-
O- She came
It
out
actually
of,
helped her.
so
Oh,
she
she did
came
get a
out of the
permanent.
OR
Oh.
with with just ventricular pacing.
Uh-huh.
And so, and Kathy did thoracic echoes, and she determined that she had about a 35 millimeter gradient from SAM with ventricular pacing. And with the AV pacing synchrony, she thought that it went down to about a 10 millimeter gradient.
Wow.
And she may have just been being nice to me, but she did say that, and the patient did get a lot better, so we're gonna just assume that that's
So
true.
Tony, one of these patients suddenly develops AFib, heart rate 150. Would be a good drug for this patient.
Well, I would be thinking DILT, because of the AFib for rate control, but let's see, we don't want a chrono, so DIG might be out, and I'm thinking my right hand is telling me a beta block.
I don't know, Megan, what do you think? What did you say?
Beta blocker and void.
Like what?
Esmol?
I was thinking like a metoprolol 5 something IV, 2-4
What do you
something.
think, Megan? Guilt or a beta blocker? Yeah, you slow down the heart rate, and actually you're hopefully maybe impacting inotropic hypercontractility, and you slow it down a little bit, and that might be a good drug.
Why
There's a lot of things.
Esmolol a good choice?
Esmolol is let's see, beta specific Esmolol is beta specific.
What's the other name for Esmolol? There's the
Brevibloc.
answer. Brevibloc. It's very short acting. You can't go wrong. If you made the wrong choice, you effed up, you stop it and it goes away in 30 seconds.
Metoprolol might hang around a little bit longer.
Oh, that's interesting.
Yeah, so it's an all drip.
You get a little bit more.
We don't use it much, do we?
We don't.
We don't understand it that well. I didn't realize that it was
Well,
that bad.
actually, Esmolol can be delivered in two different ways, in constant infusion, but there's also a bolus, and the bolus is very easy to give. It's a 0.5 milligram per kilogram, and you just boom, shoot it in.
And the
And
half-life
things
is-
could go terribly right, or they could go terribly wrong, but it's only gonna be terribly wrong for 30 seconds.
Oh, it's that fast?
Yeah,
Really, that quick?
yeah. So you're
That's
not
kinda-
gonna, you're not
Yeah,
gonna
we would
make a
do it
move.
for like off pump and stuff, right? We'd give a little Esmol for just a little
Absolutely.
challenge, and the heart would stop, and it picks right back up.
You're not gonna make an irreversible mistake with Esmol. It's sort of like adenosine.
Guys, I have to go to dinner. I want you guys to continue the discussion if you want to continue.
Yeah.
the discussion.
Okay, well, let me-
I really, really apologize.
I'm saying-
We had one of the best conversations where
Thanks,
we
Lisa.
had Sam's,
Thank
but
you.
it wasn't Sam's. Like it was a Sam.
Sam's is a chowder house.
She didn't have Sam, but she had the propensity to have Sam.
Who is this?
I don't remember the patient, but I remember the conversation with her.
Okay, so a couple of things about this is none of this happens in a vacuum, right? So, like we were saying, there was a patient where dobutamine seemed to work. I don't really remember that patient particularly well, but you know, if the engine is really bad, if the ventricle is really shit, then you just might need contractility, either of the left ventricle or of what Luis was saying. You know, the only way to get the left ventricle to fill is if your right ventricle is working. And if it's a case where the right ventricle just does not have the juice to get blood across the pulmonary vasculature over to the left side, then you're never going to fill the left ventricle anyway. So that may have also been the case. And notoriously, when we do heart surgery, the ventricle that is less well protected, when we get cardioplegia and we try to protect the heart during that period when the heart is clamped and not getting any blood, the right ventricle, more often than not, is more damaged than the left ventricle. And there's a couple of reasons for that. First of all, the right ventricle is less well perfused. The right coronary artery, or the branches that go to the RV, are fewer and farther in between. It's not completely infrequent that the right coronary artery will be the more diseased of the arteries, and so cardioplegia is administered. In the days when we were using retrograde cardioplegia, and we've gotten away from that a little bit, but we still use retrograde cardioplegia, the distribution of blood back to both ventricles is not proportional. Much more of the cardioplegia goes to the left ventricle than goes to the right ventricle. And then lastly, we protect the heart when the heart is cross-clamped by two means. We stop the heart, taking away its workload, so it doesn't have a lot of oxygen demand. So we rest it, and we stop it in diastole in its completely relaxed state. You can also stop the heart in systole with calcium. That would be exactly the wrong thing, because when the heart's not getting blood, you don't want it to have an increased oxygen demand or an increased need for ATP. You want it to have less. So calcium will kill the heart. We stop it with potassium, which stops it in a relaxed state. Okay? And so the retrograde cardioplegia is less effective to the right side, and frequently even antegrade cardioplegia is less effective to the right side. But there's another aspect of it as well. When anatomically, in particular when it deals with the heart, left is not left and right is not right. Left is posterior and right is anterior. Okay? So that when we give cardioplegia, what I was saying, there's two ways that we protect the heart. One is by stopping it in a relaxed state, and the other is by keeping it very cold. So the cardioplegia solution that we inject is 4 degrees Celsius. And what the cold does is exactly the same principle that you're employing in room 7, is tissue uses less oxygen when it's cold. That's why if you drop your baby off in Lake Erie in the wintertime and they're at the bottom for 25 minutes, sometimes, I mean, don't do this, I wouldn't drop the baby off, I'm just saying. Sometimes they don't have any brain injury whatsoever, but take that same scenario in the summertime and they'll have, well, you guys you see it with the hypothermic when they come in with the post-duress. With the right ventricle being anterior and the left ventricle being posterior, the left ventricle is very cozy in the back of the pericardium, and it is insulated from the heating effects of the lights in the room, from the ambient heat in the room, and so it's way more difficult to keep the right ventricle cold. And so it's not as well protected from not getting as much cardioplegia. It's also not as protected because it's more routed to warm. And so the right ventricle can be stunned as well. And if the right ventricle is not functioning, then the left ventricle is not going to get adequate amounts of volume. So that's one reason why that may have worked. Although that's speculative.
Right.
Right.
And every case is so different.
Every case is so different, but you know, when you say that your first case of SAM was 15 years ago,
That's the only one that I
wasn't. It's the
remember.
first case that you knew was
That we knew was
So
Sam.
then, how many cases either before that or since, in between, did people just circle the drain and oh shit, and we go back to the operator, they just died, or they didn't do well, or they struggled,
Right.
and maybe it's because we were doing exactly the wrong thing. But it's also exactly the wrong thing to avoid inotropes if you do have a weak heart and there is no SAM and this isn't an issue. And so if it's not recognized as the etiology, epinephrine is a great drug.
Of course
We use
it is.
all the time.
Yeah.
Dopamine is the bomb.
Right.
We don't use enough dobutamine in my estimation. And Luis doesn't like dobutamine because of experiences he had in the dog lab
Right.
at Stanford. I mean, we use milrinone, but I don't think we use enough dobutamine when we need just a pure beta agent.
Right.
I always look at it as, you know, epi is, I like epi when I need beta and alpha.
Mhm.
I like Levophed Neo or Vaso when I just need the alpha. But I like dobutamine when we just need the beta. And we tend not to do that. I like milrinone a little bit less well because milrinone doesn't have the same direct cause and effect as these other drugs. It doesn't work through neuroreceptors. It works through a mediated response with cyclic AMP. So that's why if you're on milrinone, you can shut the milrinone off. I don't care if you're on, you know, 0.5 of milrinone and we say wean it, as far as I'm concerned, just shut it off because it auto weans over the next 6 or 8 hours. But like all these other drugs, you turn it on, there's an effect, you turn it off, you lose the effect. I mean, not immediately, pretty close to immediately, right? I mean, you see changes when you go up on Levo or down on Levo or Epi or Neo. The reason I actually like Levo, I mean, I don't get to run the show, so the reason I like Levo better than Neo is because it's a much more concentrated drug. You know, if you have somebody on 100 of Neo, you're giving them like 120 cc's an hour of fluid, and usually we don't like doing that unless you're putting an outrageous amount of Neo in there. So that's why I prefer Vaso, or
we don't use levo much, but levo is an excellent alpha agent also. It's not quite as pure as an alpha agent as neosynephrine or vasopressin, but, and we all have our own prejudices and religion also. When I was young, back in the 1850s, we used vasopressin for only one thing. Anybody remember? There's some old fogey nurses here, what vasopressin was used for?
It's for
Stop.
diabetes insipidus.
Yes.
DI.
Huh?
DI.
Uh-huh.
Diabetes insipidus.
No. It was for esophageal varices.
Yeah.
Really?
Yeah.
Oh, I bet you,
Because
oh,
people were bleeding out.
though, and I'm like.
There was no better, first of all, there was no good treatment for esophageal varices. Remember those tubes you put in with the football helmets and all that shit? But if you figured that if vasopressin is such a good vasoconstrictor in the splanchnic, that it actually decreases the blood flow to the liver, and the feeling was that if you decrease the blood flow in the liver enough, you would lower the portal pressure, and if you lowered the portal pressure, you'd have a better chance of stopping the esophageal varices. But in so doing, and where I trained, we had a lot of alcoholics, and there wasn't a lot of good treatments for any of this stuff. We did this stuff a lot. We gave a lot of these people heart attacks because it caused coronary vasoconstriction. So it was not infrequent that we would put someone on a high dose of vasopressin and a low dose of nitroglycerin, paradoxically, for coronary vasodilatation in an effort to avoid that. And the only reason I bring this story up at all is that's why I'm afraid of vasopressin. Because I just had, just like Luis doesn't like dobutamine. I mean, so much of this, it has to do with religion and not necessarily fact. But from my point of view, that's why I'm not a big fan of vasopressin. It just has to do with your own experiences.
So overall with SAM, and again, this focus was just on the SAM patients, they seem to, well, the higher filling pressures are something that we tend to see as the treatment center, right?
These
That's
are the
right.
only two things, and then how do you get there? Right,
Yes.
so increasing the afterload, we know we can, aortic stenosis worked great.
Mhm. And you do that also by increasing your SVR and SVR pressures.
And increase the SVR, the aortic stenosis worked great and fine. Increase intraventricular volume. Well, one way to increase intraventricular volume is to not decrease intraventricular volume. So don't give a ton of Lasix and don't give a ton of, don't pace faster and don't give inotropes that are going to make the heart beat faster, and increase the contractility so the intraventricular volume is smaller. So avoidance, number one, avoidance of doing the opposite. And then anything proactive that you can achieve the positive. So slow down the heart rate.
And we found that, we had a patient and we took the pacing from 80 down to 70. Do you remember that in the old ICU? And the blood pressure got better.
We tried it with this lady and her pressure dropped. That was the first thing that we tried with this lady was to bring, but the problem is, and I know what you guys are all thinking, why don't we put atrial pacemaker wires in there anymore?
Yeah.
Because that would have been very helpful for this lady.
Yes.
We were pacing only her ventricle and she wasn't getting the benefit
kick.
of the 20% atrial kick, so she wasn't getting that extra
So there's the $20
intraventricular
million
volume.
question, how come?
Oh, because they bleed and
But it seemed like a standard for
it seemed like
decades.
a standard.
It's not now, and so I.
No. My wife doesn't like it.
Okay.
I can't always argue with. I can't be arguing with both my wives
At the same time. Okay, got it.
Right.
Okay.
And since I'm frequently arguing with my real wife, I can't argue with the other wife.
Would you think about putting them in for SAM patients though? Would you
I'm
like
sorry?
be
What
more?
about for SAM patients?
I think we should. I think we should. You probably noticed we've been putting them in for Maze patients. And I believe me, I recommend it as much as I can.
And do you guys ever think of like Impella short term for these guys at all?
Well, Impella would work, but I mean, that's if someone's really in extremis.
Okay.
I mean, Impella would work under any circumstance. Impella is essentially left ventricular assist. And you could, because you're not worried about the heart beating, the heart doesn't really have, or at least the left ventricle doesn't even have to be beating with at least a 5-liter Impella, right? 5 liters is a great cardiac output. With a 5-liter Impella, or even a 3.8-liter Impella, all you really have to worry is that the right ventricle gets 3.8 liters of blood a minute across over to the left ventricle, because it can't pump out what's not there, and that's something that sometimes people forget about, you know, is that you have, it's a zero-sum game. You know, the cardiac output on the right side is exactly the same as the cardiac output on the left side. It doesn't, that's the only way that it works. So as long as your right ventricle is working, you don't need anything with an Impella. So yeah, an Impella would work, but in short of spending the 25 grand, I want to go in a direction that can make them better more rapidly. And the other thing is, these patients aren't necessarily all that common, but periodically we will come out saying, don't use this as a patient, not to use dopamine. By the way, the other thing about the depressors and the drips, I didn't mention dopamine. In my brain, because of the way I was trained and the way I was weaned, dopamine and epinephrine are very, very similar. I don't see the point of being on dopamine and epinephrine. You pick one or the other. They're both alpha and beta. The difference is that dopamine, at least the way I learned it, anecdotally, I don't know if it's true, not true, what have you, is more dosage specific. You know, the classic teaching of, you know, 2 to 5 is vasodilatory. You know, 5 to 7 is chronotropic, and after 7 it gives you a lot more alpha along with the beta. And so the way I was trained is I would, if I wanted renal perfusion, and I still believe in splanchnic vasodilatation and renal perfusion, and I do think that dopamine gives you a little bit of a diuretic kick. And it's better diuretic kick as far as I'm concerned than Lasix, because it's a diuretic kick based on giving the kidneys more blood flow. What could be better than that, right? And everyone's happy with that. And then I like to adjust epinephrine up and down and just leave the dopamine there. But this is style points. It's not anything other than style points. But I don't see the point of someone being on high dose dopamine and high dose epi, and come down 1 on the epi and up 1 on the dopamine. I mean, pick one and go up and down on it, because I think that they're both extremely similar. I think that you're trying to get the same results from both. There are some studies, though, that do show that, for example, even though epinephrine is alpha and beta, and dobutamine is purely beta, that they do have synergistic effects, that the sum is greater than the parts when it comes to that.
Just a naming question with you and Sam Ash.
They'll essentially mean the same thing.
I see everything hypertrophic. I don't see anything cardiomyopic. Like I see stiff hearts. I don't see big body.
It causes a cardiomyopathy.
Okay.
So, what does cardiomyopathy mean? Cardio and myo is muscle. Pathy means no good. So something is no good with the muscle. That's all it means.
I just think of big boggy heart and not big stiff one.
A big boggy heart is specifically with, and you see a big boggy heart in people that have chronic mitral insufficiency from dilatation, chronic aortic insufficiency. These are the people that you see the left ventricular diastolic volumes are like 6, 7, or even 8, and that's the worst thing that you can do to a heart. But that's dilated cardiomyopathy. They still get the cardiomyopathy out of it, but it's completely different. As opposed to hypertrophic cardiomyopathy, it's dilated cardiomyopathy. And Hocum sort of has come to imply a slightly different disease, and it's a disease of younger people. And who is that basketball player at Loyola Marymount that died?
Lynn Myers?
No, he took cocaine on the
Oh, he shot left-handed from...
Loyola Marymount, and he died on the court.
Yeah.
He had Hocum, so this is more of a congenital problem.
Interesting.
And these patients are very, very prone to ventricular arrhythmias also. In addition to having the obstructive cardiomyopathy, they're also prone to arrhythmias. So AICDs have really changed a lot. There was a player on the Boston Celtics that had to stop playing because of this problem, because of Hocum. But the physiology winds up being the same. We also call these suicide ventricles because essentially the better the ventricle functions, the more it's killing itself, right? Because the tighter it squeezes, the more it obliterates the inner sac.
Outflow tract. Wow.
And this is completely exacerbated by alleviating the aortic stenosis.
I'm
But-
curious on the IHSS, and he did the myomectomy. How long does that last? Can they grow that tissue back?
No, it won't, muscle won't regenerate and grow back there. So that channel should stay there. And in fact, there was a patient that died here this year where this was so severe. Now normally we go, the knife is up here, right? So we open the aorta, we make an aortotomy. So that's open, and we're looking down on this, right?
Mhm.
And so we're taking the knife, oh, I'm so sorry. I need to go back. Oh, shit, sorry.
Kicker.
Oh, it's like, right.
Yeah, there's a green one.
No, but, yeah, you can't leave it. Yeah. So the knife is essentially going down here and you're cutting into the blind abyss this way. There are times that you actually have to make a hole in the ventricle here and cut the knife angle come up this way. If it's like really, really severe. We've only done that once and it wasn't successful. She died. In fact, we did it twice because that's the lady that Louise took to the operating room. I think I was out of town. She wasn't doing well. We took her back to surgery a second time the next day, and then she died because we just couldn't get that right. And once you start, the last thing in the world you ever want to do is start cutting into the left ventricle. It's never a good thing to cut into the left ventricle. I mean, you're forfeiting muscle. Because whenever you make a hole here, you have to close it. And so you have to take big, broad stitches, and then that muscle becomes ineffective contractile muscle. And so you never want to have to cut into the ventricle. That's why we always try to attack things through the portals that God gave us, through the valve. And we frequently will cut into the atria. So when we're doing mitral surgery, we cut into the left atrium. When we're doing tricuspid or maze surgery, or some types of mitral surgery, we'll cut into the right atrium, and sometimes we'll cut across the septum then, but we try never to cut ventricular muscle if we don't have to. Does anybody have any questions about what SAM is? By the way, there's a music store in New York called Sam Ash. It's like Guitar World. I mean, it's really common, where you buy musical instruments and they also have records. So I thought that was unfair to name this.
Does myectomy equate to a left ventricular outflow tract excision?
In LVOTE?
Yeah.
Nope, it does not at all. So, I'm sorry, Jamie, this is probably the best. So this is the subaortic region, right?
Right.
And this is actually not even an accurate representation because there's different parts of the septum. There's actually a membranous septum. And so if I drew the summit of it more like this, there's actually a membranous septum here. And then there's an aortic annulus. Okay? And when we do an LVOTE, so you're looking at the annulus this way. Let's say I rotate it, now we're looking at the aortic annulus this way. Okay? An LVOTE is when we break this ring. We're not working in the subaortic region. We're actually working at the annular aortic level. It's more of an aortic operation than it is a ventricular operation. We break this ring and we create this. So this becomes that. And then this space is filled with a patch. It's hard to draw three-dimensionally, but this space is filled with a patch. And that patch is then used to close this hole. Now it becomes closed with the patch. But if you look at it in this plane, this ring is broken. You're left with this, and this space is filled with patch, so the circumference is now greatly enlarged. And by enlarging that circumference, we can put in a larger valve.
And that reduces the workload then?
A larger valve, that takes care of what they call patient prosthetic mismatch, PPM, which is putting in too small of a valve, taking God's aortic stenosis and giving a new aortic. So whenever you see somebody with a body surface area of like 2, and a surgeon put in a 21 prosthesis or 19 prosthesis, you guys aren't used to this because this isn't who Vince and Luis have been historically. I mean, you know, you guys, we're all very, very lucky, I think, to be working in this hospital. I know I feel that way very, very strongly. You don't see that. You don't see people coming back with a 21 prosthesis. I mean, I ask all of you guys that have had decades of experience here, how many times have you seen somebody come back with a 21 pig valve or a 19 mechanical valve? Because 19 mechanical valves have a better effective orifice area than pig valves. So you can put in a small valve. And trifecta valves have a better effective orifice area. The cow valves have a better effective orifice area than the pig valves. So you may see a 23 cow valve, but that's essentially the equivalent of a 25 pig valve or a 27 pig valve. But you ask yourselves, when was the last time you
What's
saw
the
a
normal
19?
size that you put in?
It depends on the size of the person.
Okay, well, an average. You were just saying that we.
So you have to index the EOA. And when an indexed EOA is, you take, just like a cardiac output and cardiac index, so if you have a cardiac output of 4 in a 180-pound person, you're fine. If you had, by Tony,
He's in charge.
if you have a cardiac output of 4 in a 500-pound guy, it's not the same thing. And conversely, if you have a cardiac output of 2.5, who took care of our little lady last week? She weighed like 60 pounds, Mrs. McConnell. I mean, she's just like the tiniest little thing in the world. If she has a cardiac output of 2.5, that's fine. It wouldn't worry you because your cardiac index is. Well, they do the same thing with valve orifice areas. So we have a chart in the operating room, and we ask the perfusionist, what's the body surface area? We go to body surface area, we go to size of prosthesis. Now, we don't do this anymore because we have ideas in our head and we're good, but every valve that every company makes, so the Trifecta, the Epic, the Mosaic, the St. Jude Mechanical, the different series, the Master Series, the regular Standard Series, they all have a card that Michelle Boyer can show us that you go to body surface area, you go to effective orifice area, and it either shows up with a red, yellow, or green and a number. And anything above an indexed valve area of, I think it's 1.8, you're in the green. Anything from like 1.6 to 1.8, you're in the yellow, and anything below that, you're in the red. And you're going to probably wind up with effective mismatch under those circumstances. So it's indexed, depending on body size.
So what we're saying that we don't see here?
You don't see patients coming back with a 21 valve, a 19 valve.
Because it was put in wrong in the first place.
Because an inadequate valve was put in the first place. Because of fears. I mean, if you put in too big of a valve, then you can obstruct the coronaries, for example. You can cause a tear down in the aortic root. If you put in too small of a valve, then you wind up with mismatch. But it's shocking sometimes that people don't have the experience to do outflow tract enlargements or don't understand the differences between the valves, and that's where you wind up having that. And you may be fine in the operating room, right? So the patient's under anesthesia, and they don't have a tremendous workload when they're under anesthesia. The afterload is reduced, and it's under perfect and ideal circumstances. The anesthesiologist is giving medications to kind of balance things out. But now you're trying to extubate that patient in a situation where they're under far more stress, or even if you get it past that, 3 months later they try to go for a jog, and now you're stressing the system, and it doesn't work.
Is there a
I know
way
we're
for
getting
you to
off
test?
topic.
Is there a way for you to test for SAM in the OR?
You can do exactly all the wrong things and see if you see it on the echo.
And do you do an echo on all your hearts
Every
before?
heart has an echo in the operating room that we rely on. They all have the transesophageal echo. So that's the other reason why we're blessed to be working in this hospital. That's not uniform. That is something that Vince has brought to all the places that he works, El Camino, and I don't know if he's working in the city anymore, in Monterey, where you have somebody like a Kathy Bianchini or or Christina Martino that comes in and is absolutely dead expert at doing these kinds of things.
So you can do the echo and you can see if the patient
You
has
can,
SAM.
we have better examples of SAM that you can actually see
Interesting.
where this thing, instead of it closing posteriorly, it closes
Not pre.
progressively more anteriorly. And eventually this one just flops back in the breeze and causes this obstruction.
And that's what you see in
On
surgery.
No, we can never see it in surgery. And the reason we can never see it in surgery is because we're operating on a stopped heart.
So you do this before you.
We do the echo is only effective. The echo is, that's the problem with a lot of the things that we do, in particular mitral valve repair. We're operating on a static heart,
Right.
and we can make it all look very nice when the heart's not beating. But when the heart fills and starts to beat, it's like proving that, you know, the refrigerator door light goes out. No, you can never do it because the door's closed when the light goes out, right?
Ah.
So that's how we are. That's why we rely on the echo. But Kathy or Christina leave the operating room when we're on the heart-lung machine. There's no need for them to be there.
So if I'm understanding, you do this before.
So before we go on
And then
pump-
do after to confirm that your
That's exactly
repair
right.
is perfect.
That's exactly right.
Okay.
On every patient.
On every patient.
So you get a baseline.
Right, so we're looking for SAM, but we're also looking for ventricular function. The preoperative, on the mitral valve, the preoperative echo will help us to see what's wrong with the valve, to give us a little bit of guidelines as to how we might approach the repair, because there's so many different ways of repairing it. It will tell us if there was a previously undiagnosed ASD or patent foraminal valley. After the procedure, before the procedure, we're looking for clot in the left atrial appendage to make sure that if it's there before the surgery, either we go and get it or it's still there after the surgery, that it didn't embolize to the brain. After the procedure, the things that we're looking for in the transesophageal echo are the right heart and left heart function, the quality of the valve seat in the aortic position to make sure there's no perivalvular leak, the quality of a mitral valve replacement, saying whether there's a perivalvular leak or a repair to make sure it's not regurgitant. But we're also looking that we've adequately evacuated all of the air that enters the heart when we open it to do valve surgery. And so we have all of our vents in that are evacuating air, and we don't want to take those vents out prematurely. And that's another reason, that's one of the reasons why we have the valves, the ASDs, the VSDs, and the ventriculotomies, the aneurysm repairs. They lie flat for 4 hours. Because even if we think by echo we got all the air out, maybe there's a pocket that we didn't see, and we don't want the patient to sit up and have a stroke. And the theory is after 4 hours, even though air is poorly dissociatable in water or blood, that after 4 hours it will dissociate and that air will dissipate. One way that we combat that in the operating room is we flood the field with carbon dioxide, which is more freely dissociatable in water. And so it's also heavier than air. So what we hope to do is displace the carbon dioxide down into the cardiac chambers, which would displace the air out of it.
Huh.
And hopefully that will more readily dissolve. But that's what we're looking for on the echo. But I think it's malpractice to do heart surgery without transesophageal echo now. And furthermore, most hospitals, the anesthesiologist does it. And a jack of all trades is a master of none. I mean, Kathy and Christina are really top-notch. Really top-notch.
Well, I can tell you, we had a lot more open chest codes before the echo. So that has been, I think, life-saving for us on nights, don't you think? When that started?
No.
Because
that
from-
probably has a lot to do with the air.
But we were able to see if there was any clot beforehand.
Tamponade.
And then we could take him back surgery rather than waiting till that ultimate moment and then open in the room. That was kind of nice.
I'm pretty proud of the fact that we're taking fewer people back now. We took somebody back last week There wasn't actually that much there. This was a case where very little clot caused tamponade, physiologic tamponade. The echo didn't even pick it up. There wasn't that much clot, but we were sort of at wit's end in trying to understand what was wrong with this guy, because all the other boxes weren't being checked. His ventricle should have been
But
better.
you took, I remember you, that was room 9, you took it back and you ran right back.
Yeah, it was fine. Yeah, well, no, we didn't do anything.
So what was it?
It was just that there was just a little bit of clot caused enough compression of the right atrium to screw him up. Yeah. Which is good to, I mean, it's good to know. It's the kind of thing that if we're just not getting anywhere, it's a good idea to go back to surgery.
Well, especially because he was a mini too.
Hmm?
He was a mini incision.
He was a mini, was he a mini incision?
Yeah.
Yeah, he was a mini incision. I don't remember.
That was impressive, you guys did double.
Somebody, Jenny Martin asked me today if I remember the show F Troop, and I immediately remembered all 2 verses verbatim of the song for F Troop. But I can't remember last week if we did a mini incision.
Okay.
I haven't seen F Troop in 35 years.
Okay.
I mean, I can't even remember the guy's name now. Marty. I forget his last name.
He was very impressed with you too.
It's the alcohol.
Oh, okay.
Yeah.
Well, this was good. You guys have any questions?
I think what would be. Go ahead.
I didn't know you were using carbon dioxide instead of oxygen. There's so many things that you do, the
Right.
different types of valves. We never knew you were going
Okay,
for
so
one.
then this is not a one-off, so.
Right, there's gonna,
Topics
more.
for discussion,
I would love to see what all those valves look like.
I
would be,
know.
well, we have samples of them all, including now we have samples of a TAVR valve as well, so you can see, we don't actually install them, but
Are you going to?
we can bring these things here and show them to you,
we said next session would be better downstairs in radiology because it's bigger.
and that's fine.
And we could do that and we could just, there's
We have mechanical valves in the office, we have examples
I
of
think
the
that'd be
in-shield
excellent.
prosthesis that we use to replace the aorta.
Bring the
We-
heart model.
We have heart models in the office. The heart models are really pretty shitty, actually.
Oh.
They're expensive. Louise has one and I have one from different companies, but they're not that great. I thought of bringing one here today, but I couldn't see a way that it would help to explain what's.
No, the echo actually was really good. I mean, that
Yeah.
made sense to me.
But these could all be topics. And then the other thing, and I know that this becomes a logistical nightmare, especially since I don't know how it would be possible to get paid for it, but there's really no substitute to just once a year, once every 2-3 years, coming into the operating room and watching.
Right.
I mean, you're welcome to do it. There's no restriction against your doing it. I just don't think that it would be a paid experience for
No.
you guys.
Some people would
I
volunteer.
think most
I-
people
I
would do
would.
it, regardless
Well, I
of
mean, because
being paid.
I hope everybody knows that you're always welcome and we love it and you get to see.
We do. Oh, you didn't know
I
that?
didn't know that.
Oh,
Is there any liability issue?
Yeah, there's a big liability issue. You get to see how grumpy an old fart Taman is and how like airheaded Louise is and how I'm the only sane one. But that's
I'd
about
love
it.
to.
Yeah. You could come in 2 at a time. I mean, like women like to go to the bathroom in 2s. You know, you can come into the operating room.
Do you always use the TV thing so we can see the screen?
Yes.
Okay.
Yes, but more important than like knowing where to put the stitch with the mitral valve repair, I think, is all these other adjunctive things that is done both. I think it's great for you guys to know what the OR nurses do, because they work hard, actually.
Oh, yeah.
And for them to know what you do here, I mean, I think that the advantage that we have is we oversee all of it. So we know what goes on in an ICU, we know what goes on in an operating room, in an emergency room, in the CSU, so we get that kind of overview thing. Sometimes you guys could get blinders on because you only see it here, but it would translate very, very well, I think, if you knew what some of the terminology was that we use in the operating room and what it really means, what the techniques are, how air gets in, how we get it out, how sometimes we have a hard time getting it out and sometimes leave some in there. And Christina is very good with showing the echoes, and it's not just that the camera, the headlight camera can be put on the monitors, so too can the echo, so too can the angiogram and x-rays, and will be simultaneously put up so you can get an idea. And I think actually that's very underutilized here, that you guys come in, and again, I think part of it is nobody's gonna give you paid time off to do
Right.
that.
But that's, you know, still people would love to be able to go in and learn, just like today, coming in, being able to listen to you guys and to be able to share, and
You know.
it's been wonderful, thank you.
I'm more algorithmic than Luis's. Like, things have to make sense to me, and when things don't make sense, I feel your pain as when there's more of a haphazard kind of approach. Luis is successful because he's an artist. He's brilliant in what he does, and it's not always easy to teach art. It's a lot easier to teach algorithm, and that's how I think of things algorithmically until I panic, and then you start throwing everything you can at a dartboard. But before you start to panic, I always think that it's better to try to think about what the potential problem is and what the logical solutions are. And so sometimes, no, it doesn't make sense to put the patient under the, and that just absolutely does not make sense.
You guys are different when you guys are on call, because
It absolutely does not make sense.
It is hard for them.
It absolutely does not make sense to be giving these patients Lasix, especially the first night. Because yes, it's true that their weight may be up 4 kilograms, 6 kilograms, 8 kilograms, 10, 20, 50, 90 kilograms their weight could be up. It's not intravascular. And
Where
that's
did you
all the
learn
hard
that?
cases.
Because Vince didn't do that either.
He used to always let the patients stay positive for a
Yeah.
couple liters,
They're not
but
ready to give it yet.
We all
Right.
are ready to give it up, right? We all want the same thing, that when the patient goes home that they're at their preoperative weight so they don't have an extra volume.
Do that the first
But
time.
you can't do it because you're gonna wind up with an interventionally depleted patient. Well, you can do it, and then.
You're in more trouble.
So you,
Yeah.
not, usually not, because the
know.
human spirit is something that's
But the
remarkable. Did anybody take care of that guy we did a dissection on, Mr. Ramos, Gregory Ramos, and wound up, his balance was a little bit off. He had
I
really
remember him.
infarcts. Well, he had multiple cerebral infarcts before surgery, because he had this intramural hematoma. So on the way out the door, we got CAT scans and MRIs and stuff like that. His brain looked like Swiss cheese. I mean, it looked like worse than Swiss cheese. It looked like I envisioned, I'm not gonna say it. Anyway, so I saw him in the office yesterday. Guy's normal. It's like unbelievable, and yet some people, you a little tiny, and I mean the human experience is just sometimes inexplicable. So most patients, you can formulate them, they're indestructible, and nothing's irreversible. But if you do pound with Lasix early, then you're going to get a bump in the BUN and creatinine, and it comes back down. So it's after 5 days, if you treat someone the way I treat someone, you treat someone the way Luis treats someone, they wind up at the same spot 99 times out of 100. But on these patients, I'm sorry, that's counter to this, right?
Correct.
That's the exact opposite. So
and it made it
to me,
really hard. I
it
know
doesn't make any sense.
It was really hard there was an order to do Lasix and people had a hard time with
And
it.
then Diarrhea, and so to me, I feel your pain because it doesn't make any sense to me. Now, if the patient is clearly in congestive heart failure and you have other objective criteria that say that you need to get rid of volume, you're hypoxemic, you have rails, peripheral edema, that's a different story. Of
But there
course,
wasn't
were
an
times-
increase of to demand.
Right, so that wasn't the issue.
Yeah, it was just
So,
oh wait, that lady there was, wasn't it? She
mm,
went into oxymask by the end of that night.
Yeah.
Oh, did she?
Yeah,
okay.
and then that's when you said, let's get a Lasix.
Oh.
Because she was stopped peeing also.
Right. I mean, and the other thing is you have to be able to be fluid and change your mind because, and I'm not bitching about anything. Luis is brilliant, but he's artistic in the way he does things, and it's a little bit by feel. You have to be able to change. You can't say it's now 8 o'clock at night. I don't want you to touch anything till 8 o'clock tomorrow morning. Well, what if things change? Of course, things are going to change. You know, so I mean, maybe you can say, no, I want to keep some inotrope. This heart needs inotrope. I want some inotrope overnight. well, if that inotrope is epi, what if they get too hypertensive? Well, then we can add a little nitrite. That is an old Stanford trick. I didn't train that way, but it's actually equivalent to what they call a chemical balloon pump. Epinephrine, pound with epinephrine, get hypertensive, and start nitrite. So epipride. Yes, you guys are familiar with epipride.
We used to do a lot, but
Yeah.
it was interesting the last night when I was in charge. I found myself talking to Louise and saying, okay, I need guidelines. So tell me on this patient, how do I wean the suppressors? There's 2 of them, which one's first? What's the pressure you want? And I think that, for me, that was helpful. So I
Right.
don't know for you guys that are in
But it's also
charge.
good to understand why.
Yes, and that's why I was, and he didn't always say why, but at least he was giving me some direction.
Because we used to have a team effort. We'd be able, we have these orders and we'd be able to mess with them and stuff. And going back 100 years, but Vince would say, I understand you did this, I wouldn't have done this because,
Right.
or whatever. But when we're told just don't touch anything, it's
Right,
like,
that's what I'm saying. I agree with that.
yeah.
Yeah, I think you
What we do
have,
for- what
I
we
think
do-
you have every right and actually responsibility to just say why. And I hope this is indicative of that we're very happy to have a team. I mean, we wanna do this, I'm happy to do this every month, I'm happy to do it every week. If there's topics, and sometimes, there won't be something that we wanna talk about, sometimes there will be interesting patients, sometimes there won't be.
And we've got a list already growing, so.
No, but this business about visualization of actually seeing what these valves, and we talk about it, but it would be nice, there's something about tangibly being able to conceive of something and touch it and hold it and know what it
You
means.
just
the
always ask me,
spreads.
what did they put in me? And I'm
What
like,
I get.
a valve, I don't
Right,
know,
'cause
it doesn't
there's
mean
a lot
anything
of
to me
things.
either.
Right.
Yeah.
I mean, and then when I say effective orifice area, I don't wanna go into it now, but you need to know what that means. Or, why is a pig valve, have a better effective or, a lower effective orifice area than a cow valve? And they both have lower effective orifice areas than a mechanical valve. These things that we can show you, and it's much easier to explain and show you rather than just to explain it without having a good thing in front of you.
Good.
All right. I don't want to miss Jeopardy.
We won't let you miss Jeopardy. Anyone else have any questions right now?
I'm recording it.